in parts of the country. And so I think somehow, and I don't want to disappoint some of the folks that put this together, but it is going to be very, very difficult, I think, financially for us to hold off on the enrollment and then try to change and redo a proposal this year. In fact, the guy that made the presentation in our group said, there's no guarantee it will impact cost right now. But he said what it will do is it will allow us to position ourselves going forward to try to identify areas that we can meet the challenges that are going to be coming in the future and help to mitigate some of the rising costs then. So I don't know. I didn't make the thing. I don't know how we got, it seems like we're listening to a point counterpoint. And that's my focus on this is from that consultant, from y'all, I want to hear things that, oh yeah, that's on the fringes. It may not work for everybody, but it may here and there. And with 3,000 employees, that's going to add up, and we're going to maybe be able to hold down some of the costs because there's, like the Peach Care. Why would a new employee with, like you mentioned, 4 children making under $40,000? Why in the world would they not look at Peach Care? The out of pocket right now is around $12,000 for a family. So it makes perfect sense for them to look at something like that. Employees that are still here at 65, depending on their health, it may benefit them to look at Medicare. I think it's simply that education piece that is so hard to achieve, partly because the employees are confused by it and may not be willing to sit down and go through this. There has to be a simplistic way for us to make sure they understand all their options. And that's what I got out of that. I think we have to identify the options and then just clearly explain to the employees how they play out and help them determine where their best route is. Because it's not all about saving money. It's about balancing act, making sure the employees get the best coverage possible and not breaking the bank.
Right.
So I'm done.
Well, and I was going to say it wasn't intended to be a point counterpoint, but I felt like we needed to answer all of your questions that came up. I mean, if we had those questions in advance of last meeting, we would have been prepared to answer them at last meeting. We just didn't know that those questions were going to come up, and so you wanted to know the cost of delaying because of the things that you had heard, obviously, from the vendor. You wanted us to pause and take a look at those things that came up at those series of meetings that were held. And so we wanted to address your question about, what did it cost us last time to delay? What will it cost us this time to delay? And I think we answered that. And then we wanted to make you comfortable that we were not overlooking something that would reduce the overall cost of health insurance to our employees. And so we felt a need to address the things that were presented to you in the presentation so that you're comfortable, because ultimately we need a vote because open enrollment starts October 6th. And the only way we could make you comfortable was perhaps to answer those questions that were highlighted in that presentation related to these points that are being made. So it wasn't intended to be counterpoint, but to make sure we make you comfortable by answering those questions so that we can ultimately get a vote on our health insurance and have open enrollment in October. And we hope certainly that's possible by answering these questions today.
Right. And so really, as Councilor Henderson indicated, there's not really any one recommendation that's going to be that silver bullet for 2017 where we can revise the proposal and immediately see a cost reduction in the projections. But all of these things that have been recommendations from outside counsel, from Shaw Hankins, we just wanted to address these that have been considered, those that are slated to be reviewed, and to assure you all that we are looking at all options to manage the cost of the health plan. So Just again, to look at implementing the telehealth option was a recommendation that has already been slated to be introduced January 1st of 2017. It will include Teladoc, which is the first and largest telehealth provider in the United States. It provides 24/7 access to a physician either by phone or through an online video consult, where the doctor's going to provide a diagnosis when possible, a recommendation for treatment and follow-up care, and then they can also write a prescription and have that available at your pharmacy for you. So it can avoid that employee or their dependents having to go to urgent care, going in for a doctor's office visit, or even emergency room care. So again, that is a savings to the plan and claims expense, and it's also a savings to the employee because they're not paying a copay for that consultation, and it's a convenience for that employee where they can receive that prescription called in overnight, and then they're not missing work the next day. But this program also includes health advocacy, where a team of advocates can help employees navigate the insurance and healthcare system by locating providers, researching treatment options, helping them resolve claims, and providing medical explanation for any recommendations that they receive for care from their physician. There's a medical bill saver program that's also included, where negotiators will work on behalf of your members to negotiate any medical bills that they're receiving based on what's due from their deductible or any out-of-pocket expense, to make sure that they're paying the lowest available cost to those providers. There's a 24/7 nurse line for questions and advice, where that would differ from the Teladoc, where you have a true consultation and you can receive recommendation for care or prescriptions with the Teladoc alternative. Doctors Online provides access to specialists online, where you can email them with questions. Say if you have a dermatologist question or you need a second opinion, that's going to be a resource online for employees. And then Health Wealth Connection provides them with tools for physical, mental, and financial health. So kind of like an employee assistance program to focus on all of those areas. So all of those are included in that program. The next recommendation was to implement a chronic care program. So that will be administered through the Health and Wellness Center. We've discussed the wellness initiatives with our Health and Wellness Center and that new vendor that was implemented this year. So those on-site health coaches do assist members in managing their chronic conditions by helping them set and adhere to their specialist appointment, monitoring their vitals, making sure they're taking their prescriptions, and providing them access to those prescriptions, because as you know, many maintenance medications are available within that Health and Wellness Center at no cost to the employees. So that can help them manage those chronic conditions if it's available there. And then helping them with things like diet and exercise, and making sure they're staying on the right track. But in addition to managing those chronic conditions that these members may seek care for, the Wellness Initiative is focused on identifying those members that don't know they have a condition, because maybe they haven't had an annual physical, so they don't know that they have high blood pressure, they're borderline diabetics. So with that initiative, to have these employees complete their biometric screening, complete a health risk assessment, the goal of that is to identify those members that have some sort of condition and they are completely unaware, so that we can help them manage that with these health coaches to get them healthier. And then in turn, that can help us manage our healthcare expenses down the road by avoiding someone with high blood pressure having a heart attack. So that cost avoidance for those potential high-cost claimants by identifying these high-risk participants earlier and helping them manage their conditions and to become healthier. And so in addition to that, we just kind of went into the health risk assessment, determining who's high risk and stratifying those risks, and to provide year-round support, so normally monthly health coaching for these high-risk participants to help them manage their conditions. Recommendation number 5 was to use data analytics to focus on managing those specific conditions or types of utilization that are driving costs to the plan. I did indicate earlier, part of our scope of services and what we provide to the city is monthly reporting to evaluate trends in our medical and pharmacy claims expense so that we can identify any spikes in utilization, what's driving that, how can we mitigate that, and if we can't, how do we plan for that in our budgeting. And then also with that Xywave reporting, where we're looking at what are our cost drivers, how do we compare to other employers and other public entities with those, is it based off of our spouse group, our children, or our employees, what age brackets are driving that, which of our employees are receiving preventive services or what percentage are receiving those preventive wellness checks, and then also looking at the pharmacy data to identify the cost drivers there. So I just included a few examples that we've looked at before with council where this first example is for 2015 data where we were analyzing those employees that were diabetic, or members, sorry, so employees and dependents, and how we compare with how many patients we have that are diabetic to the benchmark. So you see blue is the city's data, and then yellow is the norm patients with the benchmark. So we are 22% over benchmarks with how many members we have that are diabetic on the plan, and then our total paid to care for diabetic patients is 44% over those benchmarks. So again, these are examples of where we can examine where do we need to focus on care. It may be with the health coaching, helping these diabetics to get their blood sugar levels in check, to help them stay in adherence with their medication program and with their diet so that we are not incurring high claims or additional claims with managing that when they become unhealthier. This is for obesity and heart disease. So you see here we had 43%, almost 44% above the norms in the number of patients that were obese or had heart disease, and then also looking at asthma and COPD, where we were below the norms of number of patients that had asthma or COPD, but our cost per claimant was almost 54% above the benchmark. So that's an indicator that some of those are not managed well, and there are options where we can use our health coaches to help them manage these conditions and avoid those catastrophic claims. Number 6 was to review the ASO vendor and stop loss. So Shaw Hankins does conduct an RFP process on an annual basis to review the ASO vendor. So that's going to be in, for the city. It's administrative services only, so it's Blue Cross Blue Shield for the city, so it's the vendor that's administering our medical claims since we're self-funded. So we do review other options, so any third parties that would administer claims, any other carriers, so we're looking at Aetna, Humana, United Healthcare, all carriers that have a network and the capability to administer our claims program, and we're looking at what's their fixed cost in comparison to our current costs with Blue Cross Blue Shield, but then we're also looking at what are their network discounts, because again, that is our major cost driver, is not just, you know, the per employee per month we're paying Blue Cross to administer our claims, it's the actual expense of those claims. And so we evaluate what networks have the larger discounts to provide us with a lower cost for these services. Stop loss was also evaluated for 2017. Stop loss is where the plan can reinsure any risk. You can reinsure normally on an individual member level where you'll have a specific deductible. A good example is about $300,000, where if any one member on the plan incurred claims that were over that $300,000 mark, the city would no longer be liable, and that reinsurance company would pay the remainder of the claims. So that was evaluated for 2017 because stop loss is not currently in place on the plan. The expense for that would be $938,000 to add that stop loss insurance coverage, but reviewing the high claimants over the last several years, we have had very few that have gone over $300,000. Currently, we have one claimant that's at about $318,000. So that would mean that'd be $18,000 that would be off of the city's liability. Annual claims. It looks at it annually, yes. And so based off of that cost for that policy and what we see, you may have a return based on your claims experience. It was not beneficial for the city to add stop loss coverage. And then the final recommendation was to consider a narrow network option where we can look at the local hospitals, local physician groups, and negotiate a direct contract with those providers to potentially negotiate a lower cost than maybe Blue Cross Blue Shield or another ASO provider would be able to negotiate. You saw in that master plan that we presented in October that was slated to be reviewed in 2018. That is a very timely process because we need to first evaluate administrative capabilities of an ASO vendor to administer a narrow network on top of the more robust national network we have in place. We also want to make sure that we're analyzing disruption to our members. If we're providing them with a specific hospital that they're going to be incentivized to use maybe with a lower deductible, what does that do to their dependents that may live out of area or to those that have a provider that doesn't utilize that facility? So we want to be able to thoroughly analyze the disruption to the members on the plan. Also to look at a projection of savings. So if we evaluate what percentage discount we may be able to negotiate with these local providers, we need to be able to project what does that save the plan and in turn put that into the fiscal year budget. And then formulating plan designs to drive utilization of those lower cost network options. And then, of course, the negotiation with the hospitals and physicians would be a very timely process. So that is something that is already on the healthcare master plan to evaluate for 2018 implementation. Okay, that's all I have.
Maybe that they ask questions along the way, but there may be more as we continue to talk. Retha, did you have something? One of the questions I have is, how can we, I know you have the Employee Benefits Committee, but if the FOP has a benefits committee, can't they come and present to our benefits committee, once a quarter or something and give their ideas so that it comes through there so Shaw Hankins can hear it ahead of time and work it into our master plan? I mean,
Absolutely.
and if you're not a member of the FOP and you're just a regular old employee who cares about health care, can we make it so through our newsletter or notices or something that citizens know that if they want to appear before, well, they can always appear before council, but if they want to appear before the Employees Health Benefits Committee, that they can do so, I don't know, every month or every quarter, however y'all want to organize it. But I don't know why you
Yes.
wouldn't have a public meeting section of your meeting.
I really would like the chairperson of the Employee Benefits Committee, Seth Brown, to come and speak to that, since
Okay.
he's the chair and he's fielding a lot of ideas and suggestions from employees. So I'd like for him to speak to that.
Okay. Hold on a second, I'm sorry, we've got Counselor Baker.
Apologize
No, I'm sorry, I didn't
for the
see it.
consultant, ma'am, if I may, real
Yeah.
quick. And I'm bringing two presentations. One was from our earlier one from our staff, where they were analyzing the healthcare fund, and the notation was in FY16, the fund nearly broke even, budgetary cash deficit $109,000. So apparently we were beginning to get something better. According to those numbers, that's a lot better than I thought it was looking. So what I'm struggling to understand is if we were beginning to get our cost more in line and our deficit was improving dramatically, and in your presentation you have a declining cost trend or certainly a stabilizing cost trend, then why a 23% increase? If our deficit is only $109,000 and we've got a flattening cost trend, why a 23% increase?
To respond to that question, Councilor Baker, that's a cash deficit. There are still unfunded liabilities in the health insurance fund that from prior years for claims that have been incurred but not reported. We still have liabilities related to that. So there's a payable that's booked on the books as well to account for those claims.
Okay, and that's not being considered on this presentation that we have here.
That's correct.
Okay. And so those payables are due what? To the fund or to the vendors?
The payables are due to the vendors. The cash deficit is for FY16, so the cash component of those payables would actually come out of FY17. So the projections that would have been made last year for the 2016 claims, part of those contributions and the budget that was set for the health insurance fund was supposed to cover all of those claims. But as Tammy previously stated, we've underfunded the health insurance fund just from prior years of our contribution levels from the city standpoint as well as the employee standpoint.
But those liabilities, and I realize they've been accrued and are there, but they have not been paid. You know, the city has not already stepped in and paid those.
We do pay those liabilities as they are due. It's just that it crosses fiscal year. So as of FY16, that was our cash, that was our cash deficit. But majority of those claims that were payables on the books in FY16 have come out of FY17's account already. So right now, the health insurance fund.
So then it just generates another shortage.
That's correct. It just generates another shortage
And I
going
guess-
into the next fiscal year.
And to some extent, it goes to one of the points Councilor Henderson made about trying to change something, because if we get into a mathematical calculation where it's just, okay, underfunded amount plus new premium cost of the market rate equals new premium rate. I mean, if that's just a rolling calculation we do every year, we're never going to get anywhere. So I think that's the frustration, is what can we do to help that calculation out? Because if we say, well, we've got an underfunded amount in the fund, so you got to build that into the premium.
Right.
And if market rates go up 5% in the marketplace, then you've got that plus 5%, and that's the new premium. And that's all we ever do, is just run through that calculation every year. So at some point, we've got to try to get that under control, because that's, to me, that's part of the frustration. It just seems like we've almost got a built-in increase because of those underfunded liabilities, and I don't know if or when we're going to catch those up.
Well, I think that's part of the plan that, Shaw Hankins has put into place with the plan design that they've presented to us for 2017, sort of accounting for the increase as well as building up some of those.
Y'all may not have put this together yet, maybe you have, as far as a timeline, but let me ask you this: as far as assuming a flattening or declining cost in the marketplace, then at what point on a timeline would we be caught up with those liabilities, so you won't have a double-digit increase? And that corresponds with physicians and specialists that I've been talking to for the last 6 or 8 months, just trying to understand all this. They've actually told me the same thing. They're actually finally starting to see some stabilization in the markets. Not just in their own practice, but some of them are on boards of hospitals and administrative positions, and they understand what's going on. And so I'm hearing the same thing from them, and then we come back and see a 23% increase. And then, we have to answer for that, and it's hard. It's hard. We're trying to understand, how does that come in, how does that come into play when we caught up where we don't have, we understand 1, 2, 3, 4% increases, 20, 25%. And it's, obviously it's devastating to employees. That's what I'm trying to get my arms around. When can we expect not to have to say 25%, 20%? And I realize that's a timeline question.
Right, and it is a good question, and I'll speak to our experience with other city and county governments, and we've had a very similar circumstance when we've come on as a new consultant, and budgeting was kind of up in the air for the health plan of who was setting that and how was that being set. So we've had some very difficult experiences coming in to set the appropriate budget on the front end of a fiscal year or that plan year, where we've had to see double-digit increases in the same circumstance that Columbus has. But for each of these examples where we've had to put in plan design changes and increases, we've seen those all stabilize, where I'm thinking of 2 specifically, city and county governments in South Georgia, that I've seen no increase for 2017 because we were able to appropriately fund the plan on the front end and build some reserves where we weren't having deficits that we were carrying over to the next year.
Okay, so we don't know really how long it'll take us to catch up and get to that point.
With this 23% increase, we're including medical trend that you indicated that is flattening. So we're including that in our projection, so that's not something we'll have to build in for the next year to double up on. But our projection is with trying to control costs with the measures that we've recommended through wellness, chronic condition management, and plan design changes, that within, a 24-month time span, that we should see a leveling off of any increases needed. And by setting the budget appropriately at the beginning of the fiscal year, we will not see double-digit increases going into future years.
And I realize on the RX side, we don't have a whole lot of control over that, but
We have more control with vendors that we are evaluating,
Okay.
so that we can receive real-time data to know what are our expenses, what's driving the cost of our claims on the pharmacy side, and helping to manage patients with those conditions or with those high-cost drugs to drive them into some lower-cost alternatives that have clinical effectiveness that equals what they would maybe taking that's high cost.
thank you.
I know you and Counselor Baker know what you're talking about, but we're going to be asked to repeat it, so I'm going to see if this is right, because it'll help me. People do, and I know they do, all counselors, they ask, can you explain that to me? Okay, so the 23% is the function of two things, and that is both increase in medical costs and the fact that our plan has been underfunded. And so you've shown us that the increase in medical costs is tapering off because of some of the steps we're taking, the Health and Wellness Center and some of the other things, and we're going to continue down that road and hopefully see even a further downward trend or stabilization. And the second thing is because of the underfunding that you all, I seem to remember this pitch last time you were here, because of your actuarial information and know-how, that you can much more accurately predict what our cost is going to be, so we will not have these surprises at the end of the year. And the 23% in part was to make up for the bad, if you will, actuarial assumptions that were made previously.
That's correct.
Okay. All right. Okay. Let's see. We have Counselor Thomas.
A couple of things. One is the finance director, oh, there you are, said, was talking about the incurred but not reported. That's an every year phenomenon, though, correct? I mean, you always have incurred but not reported claims that fall over into the following year. Is that not correct?
That's correct.
And are ours this year, how does ours this year compare to past years, if you will? Are they more? Are they less? Are they about the same?
Well, they are roughly about the same, as it's a little bit more than $2 million each as far as FY15 and what we've seen so far for FY16. But the point that I guess I wanted to make with the FY15 numbers was on top of the incurred but not reported claims, the city had to make a cash contribution to the health insurance fund. So that was on top of, because for general accounting purposes, we can't leave a fund in the negative, a cash balance of any fund in the negative at the end of the fiscal year. So the $2.2 million was a cash contribution that the city made to the health insurance fund. So my point was that although I didn't specifically say that it was a cash contribution in FY15, that's what it was. And so we have, for FY16, had to make less of a cash contribution to the health insurance fund. But the incurred but not reported claims is a phenomena that happens every fiscal year.
And that we budget for every year. I mean, we know that it's there, and so obviously when you set the budget, you take those kinds of, that history into consideration, do you not?
The budget is supposed to also include those claims, but because in prior years, just based on the projections that we received from our prior benefits consultant, I can't really say that the budget has covered, the budget plus the employee contributions have covered all the claims that were necessary for the entire year.
I guess my point is this. When you set up the budget for the next fiscal year, you know that in the medical in the health care budget, we're going to have incurred but not reported claims.
Correct.
And so you take that into consideration as you set it up. So it's not a surprise.
That's correct.
That we have these. The other thing that I wanted to address, and I know that it's difficult, this 23% increase, as I understand the conversation around the table, that's the fact that we had not budgeted enough in our health care over the last several years is the city's fault. It's not the employee's fault. It's not because the employees did something that caused that rate to go up. It's because we had to rely on the people that we had hired as the experts to give us the information that we needed to set that rate, and they gave us incorrect information. We are not healthcare professionals, and only one or two of us are financial experts, and so we have to rely on those people who give us information. And we are currently relying on Shaw Hankins to give us the good information that we need in order to make these decisions. Hopefully, once we make some of these payments that are here, like this 23% increase, in the coming years, we're not going to have that same excuse.
That's
You know, Shaw Hankins is saying to us, you need to make up for this, and here's what you do and how you do it and how we make sure that you have enough money to pay the bill. And so ultimately, our goal is, in the very near future, I hope, we will not have those kinds of things hanging over our head again. And I'm looking to Shaw Hankins to help us get to that point.
Right, you're absolutely correct, and that is why we use true actuarial modeling. We use an outside national actuarial firm to help set those projections so that we're accounting for those incurred but not reported claims, we're accounting for medical trend increases, we're accounting for any changes in the marketplace that may impact our expenses for the coming plan year, so that we're now able to accurately project our expenses for the coming year so that we're not caught blindsided and we're not walking into another 20% increase.
And one other thing, Mayor, that I would like to just bring up, one of the questions that I had written down is, what are you doing to make sure that our employees are aware of all of these things that you've been talking about are there? And I hope that whatever you are doing, you'll make really sure that our employees are getting that information, that they know that we're going into teledoc or whatever that is. And one of the things that I would suggest to the HR folks, the mayor had said perhaps employees could come and address you. I guess, and I've been doing this for a while now, it always surprises me when you come with the new health care plan, because I think, oh gosh, is it time to do that again? And you've already spent months doing that. Perhaps if we let the employees know, hey, we're looking at it, and we've started the plan, we've started the planning, perhaps they would be able to give this kind of input 3 months ago, 5 months ago, when all of this was started. So just another thing to add to your plate, Retha, to
Right,
let folks know that you've started this process.
Absolutely, Councilor Thomas, and, you know, that would have been wonderful for all the information sessions that we've had, not just over the past several months, but over the past several years. That's exactly what we'd like to be talking about. I think the more transparent we can be, the employees will truly have a greater appreciation for what's going on. I'm looking at it every day. One of the things we did do is we try to post as much information as we can on our website. The presentation that Shaw Hankins presented today, it'll be posted on our website. Every presentation that they make, every presentation that I make is posted on our website. It's got a lot of details. It's a lot of deep dive, and it's a challenge for the employees to look at and absorb. But when you do put it in a PowerPoint presentation, you just hitting the high points there. So we do make sure that it's posted on our website. I've said this many of times. We got an 8-minute video out there. When we go to the employee information sessions, though, it's a little different, and I really would love for you all to come with us sometimes. The employees, and rightfully so, if I was on the other side of the table, I just really want to know how much my premium is, how much my deductible is, and how am I going to figure out how to pay it, and then is there going to be a raise in there to help me offset that cost? So when employees get absorbed with that, these details kind of get lost in us trying to share that information. But I agree with you totally. The more transparent that we can be with the employees, if we can have time, and we try to do this during open enrollment, we'll have information sessions during open enrollment where we go through the details. We talk about why our claims are where we are. We give the details. Obviously, we have aggregate information that talks about the high claims, and okay, these are high claims. It's a $50,000 claim. What is that? Is it cancer? Is it diabetes? What is it? Is it a stroke? Is it a heart attack? Is it an infant child? Those kinds of things. We can go into as much details as the employees will take the time to listen, because it's there, and it's really going to help us all, and it's going to help us limit these kind of conversations that we're having, because the employees will know. And as much as we can get that information out to them, it's really going to help us all up the road as it relates to health care.
And Mayor, I know that we have some folks here who are vitally interested in this, and I'm wondering if, will they have an opportunity to say something today?
We've
if
got
they
a
would?
couple of counselors, but I think.
I don't mean to do it right this minute, but
Sure.
at some point, they will have the opportunity to say something if they would like to.
And I think, and I don't mean to suggest, Seth, that y'all aren't, but I mean, once a quarter, have an open floor and putting in the newsletter or doing an email to all users and just saying, on Wednesday, we've got our meeting coming. If you got any ideas or your cousin has a good plan, come and tell us, because then we can work through it.
Yes, ma'am. And I would say that in the past, this is a new committee, in my opinion. We've had some changeover in the members. The former chair, I think, was so busy with his position, he really didn't have time to attend the meetings. Being the current chair, I told Reatha, I said, we're meeting quarterly. I don't think that's enough. I think we need to meet every other month, and we may even need to go to every month at this point based on how much information we're receiving. I also, and she's been very receptive to that, we also have said we wanted to entertain ideas from the employees, whether it be outside agencies as the FOP has done, or other organizations, so we can get those ideas as we go forward. I told Reatha that, although that we spend so much time on employee benefits as far as health care goes, there's a wealth of other knowledge I think that our employees don't understand or have their head wrapped around, like the 457 plan, and they don't understand how much it takes to retire in today's environment. So we need to educate that. So there's a lot of things that we're doing differently, I believe, as far as a newsletter, as far as putting it on our Facebook pages or emails or whatever the case is. I probably spent half my day yesterday talking to employees about this day, about what would be discussed, and the plan that was Aspirion came up with, and what was discussed with that. So my door's always open. Hopefully it doesn't take over my regular job, but I think that we need to be a conduit for the employees just so we can have the information. I think that partly was our fault, that we didn't ask, the committee did not ask the questions. I'm not sure we knew what our role was, to be honest with you. And so we have taken a different direction to where we're more outspoken. We ask a lot of questions. We want that information so we can pass it on.
Okay. We've got Counselor Garrett.
This will be for, I guess it's kind of a two-part question. They'll involve Shaw Hankins as well as our finance department. I just want to clarify, and I'll give you a chance to walk up there too. On the PowerPoint where it's talking about the additional contribution needed, the $2.3 million, if we do not adopt the plan design changes, is that that's not delaying open enrollment, but if we were to do open enrollment in October, but keep the plan we currently have, is that the amount we'd be looking at?
Yes, sir.
Okay. And this is the Shoal-Hankins part. If we go ahead and implement the telemedicine, which, I mean, theoretically, I mean, the only times I've gone to the doctor have been for a Z-Pack, which I could do over the phone using telemedicine.
Right.
And we implement some of these things that we can do immediately, like the peach care. What kind of impact, have y'all done any type of projected analysis, could that have on that total contribution needed if we were to keep the current plan?
We would have to evaluate utilization over the year of the telehealth and transition to other programs such as Peach Care or Medicare to make a projection. So to be conservative in projections, I don't think we would project any type of decrease in the funding level needed for 2017. So meaning that we'd need to look at utilization of those services, the impact to our claims experience over the year before we would allow for a decrease in the funding level.
Okay, so the only option we're being given really is either we're over budget 2.3 million, keeping the current plan, or we have to adopt these changes.
Yes, sir.
Okay.
We've got Counselor Henderson.
You know, and this is, thankfully for y'all, it's probably not for any of y'all. It's probably, well, maybe Rether. I think we need to have a discussion or a dialogue with the folks from the clinic, because one of the complaints and it's not a complaint, one of the issues that I hear is the accessibility of being able to go in there. I know when we first talked about the clinic, I had envisioned this situation where an employee during their lunch can run in there, see a doctor real quick, get their medicine, and get out. And I'm hearing that it's 3-4 days before they can get an appointment. And I don't know if that's just and I'm so guilty. I was on that plan, and I would just walk in, and they would squeeze me in. I didn't know you were supposed to make an appointment. But when I did, it was 2 or 3 days out. And I think that the value of that clinic is in managing some of the minor issues so they don't become major issues, and accessibility is absolutely key. I mean, whether it's most of them don't even need, I hate to say that, but a lot of folks don't even need a doctor. They can see a nurse practitioner or a PA or somebody they can just run in there. Councilor Garrett mentioned, I do the same thing. I'm old enough now where I know when I've got a sinus infection, I need somebody to get me an antibiotic and get it going. But it kind of weakens the value if I have to call and I don't get in there for 3-4 days.
Well, the Health and Wellness Center, they're open, of course, Monday through Friday. I believe it's from 8:30 to 5. And their timeline is if you call and you want an appointment, 3 days is the maximum that you would wait to get an appointment. So they're to make an appointment.
It appears it's the minimum, too.
However, they will accept same-day appointments, especially, you tell them what your situation is, and they're set up for that. They have X number of scheduled appointments, but they allow for those same-day appointments. They don't prefer walk-ins, because if you walk in, then you may have to wait longer than what you anticipate on waiting, and you may call someone else who has scheduled an appointment to have a delay in their time. So they typically don't work that. But yeah, ideally, you want to be able to come in, run in, and get what you want and get out. The unfortunate thing is it does have to act like a primary care physician, in that they have to have some type of record established on you before they can disseminate any type of
and in that
prescribed
respect,
medication.
I think that the telemed, the teledoc, or phone a friend, or whatever it's called, I think that would, where that becomes valuable, I think, is as a replacement for the clinic. Because, and I'm not advocating that, because I certainly don't think that that's necessarily, it's time to throw in the towel on the clinic. I think we have to do some analysis, though, of how we're getting our return on that. Because if we're not expanding the usage of the clinic at a rate that really is going to have a credible impact on our claims, that is going to ultimately return money back to us, then maybe it's not providing the level of value that people want. Maybe it's unreasonable for them to want that amount, but if they could go online and access somebody who can send a prescription to their local pharmacy right then, They didn't miss any time at work. They don't have to wait 3 days, and a lot of folks aren't even going to come in after 3 days. They'll suffer through the little infection and hope they get better.
Yeah.
So,
Well, yeah, absolutely. We're really excited to be able to bring online Teladoc, and I think it's going to be a complement to the Health and Wellness Center. It's going to help folks be able to get what they need from a medical standpoint a lot easier without as much investment of time. Prescriptions, though, so we're really excited about it. But in terms of return on investment, I do want Shaw Hankins just to speak to that, because we're continuously looking at the investment in the Health and Wellness Center and getting that return on value
yeah, I'd
that
be
you're
interested to
expecting.
hear how that is a compliment, because to me, if you're going to pay between $5 and $7 per person per month on the or electronic method, that's in addition to what we're already paying. And if we're not going to exponentially expand that usage, we're not going to see a decrease in enough premiums. Go ahead.
Sure.
So-
And you know, that's, as Retha said, that's something we constantly evaluate with any clinic that we have in place, is that return on investment. And so when we evaluate that, we know that the return on those services, the incremental savings we see for someone going to the Health and Wellness Center for a sick visit versus going to their primary care physician. There's savings there, but it's a small incremental savings for every service that we have done through the clinic, for lab work, for services, for prescriptions. But we do see a savings on there, but where we see the greater savings is by having that clinic administer the chronic condition management and the health initiative, the wellness initiative. And so that is our goal this year, with providing that incentive to participate in the wellness program, to have your biometric screening with the Health and Wellness Center, to participate in coaching if you're high risk. That is where we see the larger return, by decreasing those number of members that might be borderline diabetic, by bringing blood pressure into line, by identifying those through these wellness initiatives and helping the members manage that. That is the larger return on the investment. And so that's something that a Teladoc or telemedicine type program can't manage, where we see a very strong value with the clinic being able to provide that.
Madam Mayor, just a question. Who are the likely employee users of telemed? We've got a large pool of laborers, or people who fit in that category. I'm just trying to get an idea. Who's the typical? And I'm glad we'll January 1 going into telemed, but who's a likely user?
We see it all over the board.
And I like referring to it's our Health and Wellness Center and not clinic.
Right.
Because it brings a different thought to some.
Right, and that's truly what it is by managing.
No, I was just wondering, is an employee who's filling a pothole likely to be a user, or is it the IT professional or someone, administrative assistant? I'm just trying to, yeah. Well, I know it can be anyone, but I'm just.
Your question is that you're wondering if there's any specific occupational category that would be using it more, and to your answer to your question, no. Telemeds can be used by various demographic.
Yeah, I understand that.
You know, so.
Yeah, I understand that, but when we talk about, it sounds like there's a question as to whether the Health and Wellness Center is a viable option going forward, because we have telemed, and who's comfortable with what, and I'm just trying to get a sense.
Okay. Well, just because
Yeah.
the Health and Wellness Center is going to. I'm just going to be honest with you, because for chronic illnesses, for postpartum avoiding, diabetics, cardiovascular, obesity, the whole sphere, that center is just invaluable. I mean, and it should remain as it is. Okay, one. But as far as telemeds, it could be used for anything. Someone could, let's skip what could have a sinus infection, call, get something right away. A lot of times it's for it helps people that they think they have something major and it's really something minor. You're probably familiar with what I'm talking about.
Oh, yeah, definitely, where they can avoid an emergency room visit.
And it's all types of various, all over the demographics for the telemed. The value with the telemed, the real value with the telemed is that if somebody feels something and they call, for the physician to be able to catch something that the person might not think is serious. That's a
Right,
big thing.
right, to catch something that might be serious and direct them of what additional care
Exactly
might be
right.
needed.
Exactly right.
And then also, for the convenience, so you asked what type of employees have we seen use this? And it is, Governor, or Councilor Barnes indicated, it is all over the board. We see public entities where, the labor groups, blue-collar employees utilize this, because it doesn't have to be a web chat, it doesn't have to be very technical experience, it can just be a phone call. And so we see families use it, single individuals, we know it's very valuable for those with children in the middle of the night or running a fever to know, is it something
go.
serious where I need to go to the emergency room or urgent care, or is it something I can see the pediatrician in the morning, or can I take care of it now with a prescription?
Yeah. And of course, I only ask that question because I just want to make sure that, because, some people have to have a visit to do right. I was telling, I think, the mayor the story where, the guy went to his doctor and his blood pressure was off the chart, and they sent him directly to the hospital, and they asked him if he was on blood pressure medication, and he said, yeah, and when was the last time did you take it? And he says, I only take it when I feel like I need it.
Right.
I mean, but if you got a free opportunity to go to the Health and Wellness Center, they are monitoring those things, and they require you to come in on a regular basis. And if you're not coming, I'm sure they're going to be calling you. Like if we gave this person a 90-day supply of blood pressure medication, and we haven't seen him in 8 months, something's going on. So
Right.
there's going to be a contact initiated where that person out there hasn't been because he or she doesn't think, well, I haven't needed it, I take it once a week. So we've got a system in place to keep us from having that huge expense that we're going to have if that person continues down that road. And that's why I just want to make sure that we see the value in the Health and Wellness Center and how, if it's only telemed, it could create a problem.
Exactly right. That is the greater value of the health and wellness.
That was my point.
Retha, if you would, make certain that the director in the Health and Wellness Clinic, or whatever the appropriate lines of communication is, I don't know. But I do want to make sure that they're not defaulting to 3-day appointments. That just because you called, I'm going to kick you 3 days out. If there's availability, they should say, are you available this afternoon? We can take you this afternoon. And I think you need to have that conversation with them, because it could just be as simple as the person who's answering the phone has been told up to 3 days, and so that person's just,
If they can
scheduling
if they can
conveniently.
see the same day, they will see the same day. I'll have the conversation
Please
again.
do.
But if
Yeah.
they can see the day that you call, they will see you that day. If they are booked for that day and it's not urgent, then they will schedule a maximum of 3 days from the time that you call.
Well, just make sure that they're giving them first available appointment.
Absolutely.
And tell me your name one more time.
Tammy Starkey.
Tammy, thank you. I know I should know that, but Mayor Pro Tem and I were having a sidebar about the teledoc, and we were both noting that we go into the doctor all the time, for all kinds of different things. And so if I need a Z-Pak, it's very likely that I could call a teledoc and say, this is my history, this is the things that go on with me, this happens all the time, I just
Right.
need this. And they would be, I assume, very likely to give it to me.
Right.
Now, what if I'm more like my husband, and I only go to the doctor when I have to? And this isn't his circumstance, but he calls to get something, a Z-Pak, whatever, and unbeknownst to the teledoc, he's got high blood pressure and high blood sugar, and he's just using now teledoc. Since he can, he would, and he's not getting those things checked. How do communities that have this function, how do they make sure that their people are actually being seen for preventive care and monitoring and health maintenance, and not just relying on the quick phone call and letting huge things go unchecked?
Right, that's great. We don't, a great point, we don't want to encourage any members that aren't getting those annual physicals or going in to see their doctor to continue to do so by just using teledocs. So that's where, when we do have a wellness program in place, as we're proposing for the city, we're providing those incentives for them to have that screening. So that biometric screening is going to check blood pressure, your sugar levels, those types of things that could identify an issue. And then you would see the health coach to help manage that. For those employers where we don't have wellness initiatives in place, that's where we promote the preventive care by having your annual physical for your doctor. We monitor what percentage of our employees and spouses and children are receiving those preventive services, as we do for the city in our reporting, and help communicate the value of those and the availability of those at no cost through the health plan.
Yeah, and I'm sure there's a system, and I'm trusting that y'all all know, and the doctors working for Teladoc all know, but I would hope there's some sort of system that regardless of what the patient is telling the doctor on the phone or on the website, that he looks down or she looks down and says, "Sir, you haven't been to a physician in 22 months. I'm not prescribing anything for you. I don't care how you know what your situation is.
Right.
You've seen nobody for a very long period of time, and you're going to have to go into it." I don't know if that will be electronically conveyed to this poor physician who's just, having to go on what he's being told. I know there's protocol and procedure. I just hope you let everybody know that,
Right.
whatever it is.
Yes.
Yeah.
Certain questions.
When was the last time you were to,
And then, see, we can tell that individuals are fabricating just by the questions that we ask. So there are certain protocols. I'm trying to think of the name, and it evades me now. It is a certain protocol. If this person says this, then you go to B. If not, they go to C. You understand what I'm talking about? So we know that. So in the case of your husband, when he asks the questions, we can find out whether he's like you.
and then they stop and say, "We're not going
Yeah,
to,
sure.
you're going to have to go in and see
And
somebody.
that's what we
It's
said.
been too
Well, I'll
long."
tell you what would be best for you is to go in and see your healthcare provider.
Yeah. Yeah, and I know it's being done all over the country. I just want to make sure for those who don't, when you look at studies, there's a direct correlation between income and the number of times people go to see their doctor. And so I think what the city manager, I don't want to put words in his mouth, but we have a lot of laborers and people at the lower, we were just talking about it a minute ago, related to other things,
Right.
on the lower end of the income scale. And if you look at the broad generalizations of studies, that would indicate to you that those individuals may be individuals that do not regularly see their physicians. And so unlike a IBM or a, Cisco or whatever else, I would be very concerned about the income-related, more moderate, more modest folks that may not have not had maybe access to medical care in previous jobs and don't have a habit of going to see the doctor. And I'm just going to leave it with you with that. There's nothing that concerns me at all about people that have regular lifetime regimen of going to see their doctors using Teladoc.
Right.
I know how that works, I can imagine. But folks that don't have a lifetime experience in a regimen, don't have the same history and so forth, I just want to make certain that they are protected and don't rely on Teladoc and are not getting chronic things seen and regularly tended to. Like I said, I know it's a whole industry. Other people have been thinking about it for a long time, and I just wanted to get that out there. So, all right. Anything else? I'm sorry, what's that?
Councilor Thomas mentioned that there was others that might want to speak.
Oh, yes,
today.
yes. Sure, we'll open it up. I thought you were retired.
I did too.
Yeah. Good afternoon.
Good afternoon, ma'am. Well, just real quick, I'm Randy Robertson with the Fraternal Order Police, and just to shine a little light on this situation, this whole conversation with Mr. Day started several months back when the educational sessions were being, there was an educational session to be held at the Public Safety Building, and needless to say, I think everybody knows the session did not go well. And afterwards, Mr. Day and I eat breakfast. There's a group of gentlemen of diverse backgrounds, and some conversation over health care came up, and I asked him if he would be willing to sit down and discuss health care with some different groups of city employees. And I had one counselor tell me one time, and I think it's actually true, and I think some of us may have experienced it today, that when people start talking about health care, their eyes kind of glaze over, and they start thinking about wonderful times when they were children, because it's something we really don't want to, sometimes it's things we really don't want to know and don't want to understand. But, so Mr. Day agreed. So members of the Fraternal Order of Police, the Columbus Firefighters Association, the Retired Employees Group, the General Governing Group, all met, and we had great interaction and explained the situation that we were going through. The FOP had some information mined through open records requests and things in the past that we gave him to look at, and past health care plan proposals and things of that. And that's where these ideas came out of. And so what we did is we hosted some small groups and got together with the Healthcare Committee, which was chaired by a member of the Fraternal Order of Police, and we discussed these healthcare proposals in an environment that made them a little more easier to understand and to swallow. And so Mr. Day, on behalf of the Fraternal Order of Police, helped us understand. I know more about healthcare than I probably ever wanted to know. But some of the primary things that came out of our discussion, and I saw the Shaw Hankins presentation from the back, and it seems a little more expansive from what I've seen in past, and a lot more information came out, and I really do appreciate that. And I do want to point out, you know, Charlie told us there was no silver bullet. He said that many times. He said that healthcare is tough right now, and that we really have to look, and we have to accept the fact that some things aren't good, and that some things are getting better. But you know, I think if you go back and look in the records, we discussed telemed 3 years ago, and it didn't go anywhere. And so I kind of wonder where we might be today if we would have jumped into that, you know, 36 months ago and chewed some of those costs down. Because some of the primary results from our conversations were, of course, the narrow network. And everybody from Columbus and in this area understands we have a very tight medical community here. You know, I tell everybody Columbus is the biggest small town in Georgia. There's a lot of conversation that happens across vocational and professional lines that we have an opportunity to build relationships. And even though we have 2 primary hospitals here, there are relationships within those hospitals that I think developing a narrow network is not going to be complicated if we wanted to do it here. And we've been in some of those networks before. Ron Hudson has been my physician, been my children's doctor since they were born, and he is still my physician. And I do go for my annual checkup, and he is the one that takes care of any chronic issue I have, which the fact that he's not a mental health professional, all he can really address is the fact that my triglycerides get a little high every once in a while. And he prescribes cardiovascular exercise because he knows I won't take a pill. But that, you know, that's the guy I want to see. And if he falls outside the narrow network, then I know I have to come off my wallet and pay that little bit of extra to get the care that I want, that I'm comfortable with. And that's built in, and I knew it all along. One of the most incredible things that came up was the opportunity for city employees to go and sit down with healthcare counselors that not only counseled them on how to manage their healthcare expenses, but would work with them on other finance issues dealing with healthcare, not only there that day, but down the road, especially those that have children that have chronic issues. And we've got some city employees that have some serious things under their roof. And I want to point out real quick that on the Peach Care thing that was brought up, when it was Peach Care and the Medicare aspect were all things that we felt could have been brought up in an educational forum. We're not trying to push anybody in any direction. What we're trying to do is show every option available so employees can feel that they have an opportunity to make a choice in their health care. Health care is extremely important to the men and women that work for this city. You know, we've got, you're talking about the gentleman out working on the road, and you're talking about the police officer in the car, and and the lady down in the park doing their jobs, with the stress of worrying about family health care, what kind of quality employee are we actually getting? You know, we talk about return on investment. What return are we getting from an employee who is out there and stressed over trying to take care of their family? Especially some of these families that have these horrific situations that really, to be honest with you, the health care is the reason they work for the city. It's not for the salary, it's the health care. Families qualify for Peach Care. A family of 3 making $49,632 qualifies for Peach Care. A family of 4 making $59,904 qualifies for Peach Care. I think Councilor Thomas said it earlier. I think we have a lot of employees that would catch up in that net with those type salaries. But
Randy, let me ask you before you
Yes,
go on.
ma'am.
Because someone mentioned this to me, actually texted me, it was a question I don't know the answer to, that it's not just income-based, they also consider your assets. So you could be a family of whatever making 54, but because you own a house and 3 cars or whatever your assets are, that could disqualify you.
I think it probably could, but
Yeah.
on these salaries, looking at, you know, rarely have we found some of the more extreme situations where the people are really well off. I'm not going to get into.
Yeah, I'm not talking about being well off, I'm talking about owning a modest house.
Yeah.
If
Well-
owning a modest house could disqualify you, that would be a risk, particularly when we're talking about children.
Yeah.
I mean, if I knew for a fact that, and I don't know, maybe Retha can mention it to us the next time she comes up, but if I knew for a fact that it was $59,000 and I'm absolutely qualified, no questions asked, well, you know, I would just keep my child close to me for 2 months and let no germs come in
Right.
or whatever. But if it's $59,000 and they're going to weigh how much child support I get
You're-
and all these kind of things.
You're absolutely
Yeah.
right, and all of that comes out in the educational process.
Yeah.
All those
That's what I
questions.
think would
That's
be
what I'm saying. They
waived.
look at me and say, Randy, and I can tell you, my granddaughter, my son is her primary caregiver. She's on Peach Care. She sees the same pediatrician that my friends' children see who aren't on Peach Care. Some of them employees within the government. They know my granddaughter. If you're on Facebook and you have my wife's your friend, you know my granddaughter. But that beautiful child is on Peach Care, and as her grandfather, I would not stand by and let it. But my son had to go through the process and met the qualifications, and a city employee would have to do the exact same thing. What we're offering are options for them to look at, because we have some families that feel they're trapped between the fences, and there's nowhere for them to go but to continue struggling. I mean, I don't want to get into.
I just wouldn't want them to be surprised by a disqualification
Yeah.
letter. That's my only
Right.
concern,
Right.
is
And-
that them
and
think they
Christie-
qualify and they don't.
Yeah, oh, no, you're right, and that's the thing where the education on the front end has to come in. And that's where partnerships with the state that deals in Peach Care on the day, and, you know, we all know there's offices on Comer Avenue, all they talk about is Peach Care from early in the morning until late at night. And those individuals are paid with our tax dollars, and they'll come in and educate us on more than we'll ever want to know about Peach Care. And those are the kind of resources we have to tap into if we're going to do this the right way. But along with the Medicare and everything else too, it's an option. And if it touches 2 people, those are 2 individuals that will put an additional $47, if those numbers are right, into their groceries, into their fuel tank, or into whatever, into their power bill, if that's what it is. You know, $47, there's a lot of us in this room that, you know, that's just 2 20s, a 5, and a couple of singles. But to somebody else, that's a substantial bit of money. That may be the difference between having their power on or their power off. And these are city employees I'm talking about. But we also discussed, and I know, you know, that there's going to be pushback on this, but we've also discussed about the telehealth. And there are also electronic options for dealing with chronically ill. But our goal is, and I heard somebody else say that, you know, employees go there and they get free medication. You know, I don't know what free is. Somebody pays for free. So I don't know how we get things free, but I'd love to know that information, because somebody's paying for it somewhere. And the intention of the health clinics that I studied way back when this was first brought forth by Tom Barron was, you know, the ideas I